Welcome. This is ASAM Practice Pearls, a podcast series from the American Society of Addiction Medicine. I'm your host, Dr. Peter Selby. I am really excited to introduce our speaker for today, Dr. Hendree Jones, and we're going to be talking about women and addictions. And so we are so pleased, and I don't think we could have found anyone else who would be better suited, who knows this topic inside out from women across the lifespan. And we are so fortunate to have Dr. Hendree Jones with us. So over to you, Hendree, and welcome to the show.
Oh, thank you so much, Peter. It is an honor and a joy to be here and talk to you about a topic of women and addiction across the lifespan that is near and dear to our heart and to our science. Thank you.
So we've talked before, and in your current work, you're doing a lot of work with women. And I was wondering if you would be willing to share some of the stories that, at the end of the day, it's the stories that touch us. And as clinicians, we hear it from our patients.
So when we were talking about this topic of women and addiction, we really can't talk about it without talking about trauma. That not only the events that people go through, but how you experience them and their long-lasting effects. And, when I sit in group rooms, as I was just sitting in a group room today, learning from the wisdom of women who have addiction, I was reminded of a really powerful incident that happened a number of years ago. And the topic of the day was around trust. And, we've had about 11 women in group, and they were sharing, and this one woman was talking and sharing her experiences about how she knew she could trust or mistrust someone. And as she was talking, this noise was going in the room. These were her jingly bracelets that she was wearing. And all of a sudden, from the other side of the room, this one woman jumped up and just really verbally attacked this woman with the jingly bracelets. And we all sort of stopped for a moment. And then, I took the woman who had been escalated in her anger aside. We stepped out and we did some de-escalation, some deep breathing, and helped her understand maybe what was happening with her. And at first she was like, I don't even know what triggered that. She was very defensive. We had her open our hands because it's really hard for someone to be angry when you have open hands. And with a little bit of open-ended questioning, we were able to explore together, and she had an aha moment that those jingly bracelets was what set her off. And those jingly bracelets was a sound that she had experienced when she had been abused as a child by a person who had these jingly bracelets. And it was just an opportunity for us to think about trauma that all of us experience through life and how we experience that in the here and now.
That is so compelling, and it reminds me that our brains imprint and hold on to things even though we may have forgotten it. It's still there, and a trigger like that can really bring emotions up to the surface. And, a typical way for us would be to look at that situation and almost attack and say, what's wrong with that person? Because they're so out of the realm. And really what we're really getting to is what happened to that person. So that's a great segue to get us started to thinking about, if people have been traumatized, then what are the key principles of gender-responsive and trauma-informed care that we need to think about, especially in addiction treatment across the lifespan in women especially?
Yeah, such an important piece in thinking about that brain science that we have around trauma, right? So our amygdala gets overactivated, our hippocampus kind of shuts down, our cerebral cortex shuts down, and we begin to live in that experience all over again. And so understanding that and knowing what we need to do to help people be able to access the cerebral cortex to be able to make judgments and good decisions. And so really, if I had to consolidate what trauma-informed care is, it's transparency. It's not having surprises. People that are traumatized are always waiting for the next shoe to fall. They're walking on eggshells. They're living with this vibrating anxiety. So as clinicians, literally one of the things I'll do is come in and take a deep breath with me, right? And start from strength. What matters to you today? Not what's the matter with you, but what matters to you today that you want to accomplish for our goal. So establishing psychological safety, establishing physical safety, even thinking about the environment that we have. Do we have these harsh fluorescent lights and an incredibly sterile environment with punitive signs of rules and regulations on the walls? Or do we have more comfortable chairs that fit all sizes? Do we have motivational, inspirational, calming signs on the walls? What is our lighting like? How do we have people move through? Those are some really simple things. So that physical safety, psychological safety, transparency, and collaboration. So it's shared decision-making about the treatment plan and what matters to the person.
Thank you. I think that's a great start for us to thinking about it. It's not only what we do, but it's how we are and the environment in which we work with. How do we take all of those things into consideration to making a space safer, both physically and psychologically? And is this how addiction programs are adapting their operational language to support women more effectively? And if so, are there other things that you'd like to add that programs could do or to make it more welcoming to women?
Yeah, Peter, actually, you just said the most important piece, right? Language, the words we use, that cost absolutely nothing, right? To hospital systems or to the providers. There's a great document that NIDA put out that is really focused on women. And we asked women in treatment, we asked people that were providing the services, what are the words that we should be using to help people feel more comfortable? And in fact, today I did group and I asked our women, because they couldn't be here today, I asked them, I was like, what do you want providers to know? I'm going to be talking with Dr. Selby. And they literally said, quote, I like it when a person comes from my same background. I know that they've walked in similar shoes and it makes me feel safe and comfortable. Another woman said that for the doctor not to frown on me because of the type of insurance I have right now. And then another woman said, don't use drug words in front of my family members. So that's an important reminder around confidentiality and privacy. One of the things that I know cuts across gender and sex is that idea of getting rid of the words clean and dirty when we're talking about drug positive or drug negative samples. So how we speak to our patients, every opportunity that we have, we can make people feel bigger or we can make them feel smaller.
That's so important. And I think as you're saying that, it reminds me that this is not rocket science. It's really treating people how we would like to be treated and treating people with respect and not making any assumptions in where they are and dropping the judgment. And I think that example of how you could drop judgment by simply asking people how they are and what they're doing and making them feel bigger. And I really like that how do we make people bigger? And that's our choice. That's what we hold. And I often wonder if we as clinicians are trying to make people smaller, what does that say about us? You know, we are in the service of others. And so if we are trying to make people feel smaller, that is a problem. I think we need to think about that ourselves. So I think this is a really great start as we are thinking about this. Can you talk a little bit about your experience in helping programs or clinics or clinicians begin to shift this culture to be more inclusive and safer, especially when there's been trauma involved? And are there specific examples you can give of how a clinician can take that first step?
Yeah. So that idea, going back to that, what makes people bigger or smaller, right? A lot of times we will hear from our mothers, our families who have had a birthing experience, for example, that maybe that the nursing staff treated them with great disrespect, that maybe said stigmatizing comments to them. And so the first thing I want to ask is what's happened to the nursing staff, right? I think we can apply that to addiction treatment. When we see punitive systems, where did that come from? Because oftentimes I think anger and diminishing people and putting people down is a sign of fear. Fear that I don't have the right tools. I don't know what to do in this situation. So my immediate response is, I'm going to reject you before you can reject me. So when we go in and help other programs, it's starting with the team. Where are we starting from? Does the team have negative past experiences that they need to deal with? A lot of times they might have family members that have not had positive experiences, or they're dealing with their own unresolved trauma. And when we have unresolved trauma, we end up emitting it and discharging it in different ways. So thinking about what do we need to do to support the staff so that they feel they have the psychological as well as physical tools to be able to best respond to women who have addiction. And then also thinking about, again, that sort of physical space. How are people moving through treatment? What are our protocols? And a lot of times there's urine drug testing. There's an over-reliance on urine drug testing because we have this one biological thing that we can use and we can get a result, right? And so asking those questions about why are we using this test? If we get an answer either way, how are we then going to change the clinical decision-making that we have, or what tools are we going to employ to change the person's behavior or invite them to change? And so really thinking through all those things that we do automatically can be really helpful. Getting patients feedback about how they've experienced treatment and learning from their wisdom about what can we do better.
Oh, that's really compelling. And I think there are a couple of things that are sticking out for me here. One is, I think it's so true, right? Hurt people. And so how do we break that cycle? We can model that there's a different way. Even if you've been hurt, we've created the safety and can model a way to not perpetuate that. And that even if you as a provider have been hurt, there are ways for you to channel that in a healthy way, not to hurt your patients or your clients going forward. And then again, the systemic issue of urine toxicology or drug screens, there's one thing if it's, for workplace testing or those kinds of things. But I think in the therapeutic thing, I've often found that helping people understand what the value of it is and sort of co-creating the interpretation, making it almost like a shared decision as opposed to I gotcha and I'm going to be like your conscience, but moving it more to a collaborative relationship and helping people take ownership of their own recovery in a way is the language we need, right? Otherwise, we're just becoming another oppressor of that person. Well-meaning, as we may be with urine testing, but potentially oppresses and potentially traumatizes people's privacy and a whole bunch of things. So I really think that's an important piece. So I always ask women if I'm going to test them, especially in settings where there's witness sample collection, those kinds of things. I think it's really important for us to make sure that we respect people's dignity and get their buy-in for it.
There are times when we have women that want their urine drugs to be tested. They'll come in and say, test me today. And we're really excited. And they can show that. But I think it's so important. It's one tool of many tools, and understanding the limitations of the test as well as, the benefits are for some.
Oh, absolutely. Now, when there are barriers, obviously, but this is a culture shift happening. And so what have you experienced as some of the barriers that programs face when they're trying to move a whole program into being trauma-informed and much more patient-oriented in their approach?
Those barriers can be from the macro level to the micro level, right? So making sure that we have buy-in from all of the different partners and collaborators, understanding and giving grace that this is a process. It's not going to be a one and done. That to shift any culture, in many ways, we all have to be like broken records and repeat the same things over and over. We'll hear, there's not enough time to do things. We'll hear, this isn't the way we've done it before, or, oh, we've tried X, Y, and Z. So allowing people, their own dignity and partnering with them and getting their ideas, their wisdom, just like we do with the patients that we serve, is also so incredibly important. And just one example I will give would be a move from the traditional sort of Finnegan scoring, right? That takes a lot of time. There's a lot of nursing effort, and moving to Eat, Sleep, and Console, which is a much more collaborative, patient, less of a power differential structure where parents are part of the decision making. And at first we would see great resistance from hospitals. How are we going to know it's going to work? How do we trust the parents? All these sort of things. But then once, do a pilot and you try it a little bit, and then people love it. I've seen many, many hospitals move from one paradigm to the other. So that really is a great example of moving to trauma responsive care. And once people experience it and they feel empowered by it and that their voice matters in it, we can see that there's positive change all the way around.
That's really interesting. And this goes back to when I used to do care for pregnant women who had substances. I noticed that the nurses in the NICU would come in the way of engaging the woman or allowing the woman time with her baby. And when we actually sat down and understood where the nurses were coming from, we realized that they were afraid of what was going to happen to that baby. And they had no knowledge that their work was going to mean much. They were very anxious and worried. And simple interventions like closing the loop, and at the 6-week postpartum visit, the baby and the mother would come back to the practice, but then they would go up and meet with the nurses and thank them. And they were able to see this baby in a different light. And that really helped change the culture, the attitude of the nurses towards the women when they were in labor and in the NICU in the postpartum period. But we need to help people understand that the clinicians also have concerns, and we should not invalidate those concerns, but address them as we go along. Now, do you have any ideas around where we should look for the evidence that integrating these trauma-informed care can affect the outcomes and engagement and retention?
So there's definitely a whole literature. I think it continues to expand every day just about, when we think about trauma responsive care, we know folks like Stephanie Covington and Shelley Greenfield have written papers that show that when we can provide trauma responsive approaches to substance use disorders for women, we can get higher treatment retention and better engagement. Certainly Lisa Najavitz with our Seeking Safety has shown both reduction in PTSD symptoms and substance use when we can provide a trauma specific intervention. Denise Heen also has literature around that. We see increases in improved mental health, right? And less substance use when we can really address what's underlying that motivated behavior of that substance use disorder. We also have better parenting outcomes with trauma-informed practices. We have old data as well as newer data, with Nancy Slishman, for example. So mindfulness is really an important piece around helping people emotionally regulate, and that helps with trauma and substance use disorders.
So this is really interesting, because I can think that some people might come upon this work and say, oh, well, that's all being woke and, that's not really evidence-based. But what you're saying is that there's a strong evidence base for all the hard outcomes. Being trauma-informed and operationalizing it is a means to actually have better outcomes. So you don't have to believe in it. You should adopt it because it actually shows that it works and it makes a difference.
And I would add that it can make the clinician's work easier. When we come from a place of what's happened to you and what matters to you, then that allows us to align with the patient so we don't have to work as hard.
I'm all for that. When people are in charge of their own recovery, things work out a lot better, right? You can't run an IV and then make somebody recover. So I think that that's an important piece to keep in mind. Women, as you know, biologically differ from men in terms of how they respond to the substances, but there are also gender aspects of this. And most treatment, as we know, has generally been geared towards men. So what are some of the biggest treatment gaps that women in addiction care are facing in 2025? And what are some of the things that we should be doing to address those gaps?
There continues to be a lot of gaps. You look at even the United Nations data, right? And if you are a man or anywhere in the world, you have a 1 in 7 chance of getting treatment. If you are a woman in the world, you have a 1 in 18 chance. Those are not good numbers. And so one is just sheer access. So we still, even today, have this sort of societal assumption that if there are fewer women who are identified as using drugs, then we don't need to provide as much access to treatment. And we also see that with telescoping. So telescoping is that idea of women start using substances at a somewhat later age and then end up in treatment in a more truncated sort of telescoped approach. And I think in part that's because we have much fewer treatment access spots for women. So we end up having women that sort of get squeezed in, and only the most severe women end up in treatment because that's how they kind of get the best spots. So I think access and recognizing that we need overall more services, also recognizing how substances from a biological standpoint may differ between male and female bodies, looking at just basic sex differences. And, we even know with tobacco use, right? There are both sex and gender differences. So women have a harder time quitting smoking than men do. Men are more responsive to nicotine replacement. Women are less so. And that could be a biological thing. It could also be a gendered thing. So when we think about one of the biggest fears women have, I'm going to gain weight. And so how do we address those pieces? Thinking about alcohol and how alcohol affects women's bodies in a much sort of more severe way than it does male bodies if we drink the same amount. So there are definite biological pieces, but then there's how women, in very general terms, are initiating substance use compared to their male counterparts. And a lot of times what we'll hear from the women that we serve is that it was in a sort of familial relationship. It was maybe a romantic partner relationship. And then the gendered aspect, there's this thing called being second on the needle, which is if you're using drugs IV with a mixed gender setting, men take the needle first, women get the second. So that could put women at greater risk for hepatitis C, for HIV, and things like that. So all of those things need to be recognized when we're thinking about treatment, thinking about children, thinking about transportation, thinking about women's roles in society and how they need to navigate in order to get their treatment and recover.
And as what you're saying is because the system is not geared towards it, people can get into becoming seniors before it might even be recognized. And we've got good examples in medicine where, Mrs. Jones comes into the emergency because of a fall and a fractured hip and then gets a hip replacement. And then the next thing you know, they're delirious and oops, nobody checked that actually she was doing a tea and toast diet with drinking at home with the sherry. And then the next thing you know is that she had this big complication and ends up with DTs actually. These are not uncommon presentations. So women don't necessarily present like men. And I think that's what you're highlighting is that we need to really be looking for that. And of course, with the alcohol and this young women landing up with alcohol, that it leads to other than addiction, as you said, it also leads to things like unwanted sexual activity, traumas, and those kinds of things on campuses, for example, and then things like increased risk for breast cancer. So we can see the sort of pushing of alcohol on women, but the impacts, as you said, are telescoped and happening much sooner, whether it's cirrhosis or those kinds of things. So I think we need to really look at that individual coming across. And what you're saying to us is really we should pay closer attention to the women in our practices, including general practice, because they could be hidden there.
Absolutely. And just to dovetail on what you had noted earlier with the older Mrs. Jones.
Well, not you, actually. No relation to you. I should have said that.
It's fine. So picking up on that thread of our older patient that might end up in the emergency department because of a fall. So often I hear we miss the signs and symptoms of addiction in our older population, our women who maybe have lost a spouse. They have an empty nest. They've put all of their social, economic, and emotional resources in their children. They have now gone and they haven't been able yet to find a fulfilling purpose, right? And that creates this vacuum for which substances can then come in and it's not recognized. Or even worse, we have what I would call the age discrimination where it's, she's already 80. Just let her have her alcohol. Let her have her opioids. No, everybody, regardless of age, has the right to be offered treatment, to receive it. Everyone should have hope.
And of course, we have a generation of women who begun on benzodiazepines and are now heavily dependent. And we've talked about that, how newer doctors inherit such patients and then having to figure out what to do with these situations. And overwhelmingly, they tend to be women who were started on benzodiazepines way back when, and now, of course, bearing the consequences of that. So the addiction is what I'm hearing, and I think we're talking about, is it can show up in different ways at different times, and we need to be screening and thinking about it, not having that stereotypical idea in our mind of who's addicted and who gets addicted or who comes to harm from substances when it comes to women. And it's not just when they get pregnant, it's across the lifespan.
Yeah, and not to mention high-potency THC products that are also specifically marketed to women. There's lots that's unknown about those products because they're not regulated in any real shape or form. And so how do we identify patients that might be needing help with reducing and stopping those products?
Yeah, like gummies or extracts and vaping THC and those kinds of things, which are way more potent than actually the dried flower. But of course, we need to pay attention to all of those substances. As we've talked about this, we're often really thinking about that this should be done in some sort of systematic way in your practice or a program you work in. And so when you're thinking about, or programs are thinking about implementing such a framework, what are some of the first steps that can be both impactful but also realistic?
So I think first and foremost, starting with how we identify patients that have addiction and have trauma that go hand in hand. And how are we thinking about what are the different paths or the complete same path that we are treating men and women in, talking with the patients and getting their wisdom. What have been their positive experiences? What do they like? What's working now for them? What would they like to see that changes? Because I think centering all of our work around giving patient voice and choice, which is a trauma responsive practice right then and there, can be so helpful. Thinking about how we debrief from those really stressful events. So often I hear in clinical practices, maybe there's an overdose death that has happened. Maybe there's an adverse event and they kind of get brushed under the rug, right? We should not do that because that just makes the trauma worse for everyone. And it makes us then perpetuate the problems that we've seen. So what are our policies for debriefing, for supervision, for being able to have positive wellness check-ins? One of the really small things that I've done in the programs that I've been a part of is we start every meeting with gratitude, no matter what meeting it is, right? Just a brief check-in. It could be one word of gratitude. It could be more extensive, but that sets things out on a positive so that people can be in a positive frame to be solution focused. So those are just a few things.
Thank you. That's amazing. Is there anything else that you'd like to share with our listeners as we're coming to the end of this half hour, which has gone by in a flash?
Yeah. Oh my gosh. I think that in terms of what not to do around trauma, I think that's important too. We don't need to be scared of it when we hear it. We also don't need to ask about the details. We don't need people or want people to have to dig into their trauma stories and tell us all of the nitty-gritty things. That is not what we need to know. But what we do need is to have an empathetic, compassionate, validating voice for people to know that we are here for them, to understand that we might not have walked in their shoes, but we can still have empathy for what they've experienced. And also to remember that when people experience trauma, while it might be in their past, they're not experiencing it as their past. And so it's not appropriate for us to say, that happened to you as a child, just get over it. So I think those are some things.
Oh, wow. Those are really amazing pearls that I'm going to take away and think about as I go forward with this. For the audience, are there any key takeaways that you'd like them to leave with? I know these are what not to do, but maybe some things are what to do if you want to highlight them.
Be curious about your patients. You always have every moment to make people feel bigger, to make people feel heard, validated, and seen, and like they matter. Use their name when you're talking to them. When we're busy clinicians, like making sure that we're not so focused on the keyboard and entering the information, but we're having those opportunities to look our patients in the face and ask them what matters to them.
I can't thank you enough for sharing all this wisdom in this short period of time and so succinctly and so beautifully. And with the empathy and the compassion, it's really evident. And I think we need to think about how we can all be more like this when we are with our patients and with each other.
Thank you for the opportunity to be here, Peter. It was great.
Thank you for listening to ASAM Practice Pearls. I thank Dr. Hendree Jones for sharing her insights on implementing gender-responsive and trauma-informed care in addiction treatment, whether it's at the individual level or the program, and how we treat each other. For more information related to women's care and addiction treatment, check out ASAM's free downloadable fact sheet on trauma-informed care for women with substance use disorders, which provides strategies to deliver safe, compassionate, and trauma-responsive care for women with substance use disorders. Spoiler alert, Dr. Hendree Jones has contributed to that. Additionally, ASAM offers a free 2-hour online course on patient-centered care for women with substance use disorders. Register for the course today. Don't forget to subscribe and share this episode with colleagues who may find this information helpful. Finally, with Season 1 getting ready to end, we'd love to hear from you. What topics would you be interested in hearing more about in Season 2? Please take our survey, which can be found in today's show notes, or email us at education@asam.org. Thanks for listening. We'll see you next time on ASAM Practice Pearls.